So Krista's today's speaker, and she's from the Alzheimer's Society of Chatham, Kent. The webinar is offered in partnership today with the Alzheimer's Society of Ontario in recognition of Alzheimer's Awareness Month, which is in January. Krista Schneider is a Behavioral Supports Ontario Regional Education Coordinator with the Alzheimer's Society of Chatham, Kent. Krista has managed adult day programs in addition to facilitating art therapy sessions for those living with dementia. Given her wealth of experience both in this field, but also as a care partner for her mother, who is a person living with dementia, Krista continues to be actively involved in the healthcare system, discussions to improve the experience of those living with dementia and their care partners. So now I'll turn it over to you, Krista.
Thank you very much for that introduction, Susan. So before I start today, I really just want to say a big thank you to the Ontario Caregiver organization, as well as the Alzheimer's Society Ontario for asking me to speak today. And I also want to thank everyone in attendance for taking time out of what I know are very, very busy days as care partners, especially during the pandemic now, for attending today. So thank you so much for that. And I do want to just take a moment to acknowledge and express gratitude for all you do as care partners, especially throughout these challenging times. So thank you for attending today. So just a little bit about me. Susan already introduced me. I will make a bit of an amendment. Since we began discussing this series, I have transitioned actually into a new role with still at the Alzheimer's Society of Chatham, Kent and Behavioral Supports Ontario, but I now hold the position of Assistant Navigator for our BSO program in Erie St. Clair. So that means I work directly with care partners and help them navigate through our lovely system of care for those with dementia and responsive behavior. So a little bit of a change in my role. But when I say dementia is my world, it absolutely is my world. It really, truly is. I'm very passionate about all things dementia in my everyday work, but as well as my role as an art therapist, working with those with dementia from early stage right to late stage, as well as the most important role of all, and that's as care partner for my mom, Anne. She's a person living with dementia for whom I have the honor of spending time with and walking beside through her experience. And of course, that informs everything I do in my work life as well. So today we're going to talk about responsive behaviors. This is a discussion that I have quite often with healthcare partners, long-term care home staff, community healthcare partners. And this is really the first well, maybe not the first opportunity, but the largest opportunity to share on a broad scale with other care partners about responsive behavior. So I'm very happy to share this information with you, and hopefully you find it helpful. So when we talk about responsive behaviors, just to help define that, a responsive behavior can be defined as a change in a person's baseline behavior via a new or escalating existing behavior. And so there are lots of reasons why responsive behavior may be occurring. As healthcare professionals, as care partners, it's our responsibility to be able to identify and understand those behaviors. These changes, these behavioral changes that occur, they occur sometimes as changes in the brain occur with dementia. So as that dementia progresses, sometimes we can see responsive behaviors happening as well as the brain experiences those very real and physical changes. But it's important to note that not everybody who has dementia will experience responsive behaviors. So that's a point I always like to make. I think it's a very unfair assumption to assume that everybody who has dementia will also have a responsive behavior, because that certainly is not the case. And I also really like to ensure that I advocate for the fact that a responsive behavior is not a person acting out or trying to get attention or purposely causing concern. It's a communication of an unmet need. And along those same lines, we really try and be person-centered in how we look at responsive behavior. So we avoid using stigmatizing language such as violent or aggressive or inappropriate, labeling words like that that can really be stigmatizing for the individual and that imply intent or blame. We really advocate for person-centered language, such as responsive behavior. Some people prefer personal expression rather than responsive behavior. So there are other sort of non-stigmatizing language we can use to talk about responsive behaviors. We really shy away from the word inappropriate because we very much know that the behavior we see is absolutely appropriate for the brain that the individual is working with. So again, alongside those very real physical changes that occur in the brain, the behavior that can result from that is appropriate for the brain that the individual is working with. So it's always important to remember those things. So knowing a person's baseline behavior or what their norm is essential to being able to identify a responsive behavior or a personal expression. So for example, if I'm normally a very loud and boisterous person in my everyday life and always have been, a person caring for me wouldn't classify my loud and boisterous behavior in my stage of dementia as a responsive behavior. Might it be annoying? Sure, but it's not a responsive behavior. It's how I've always been. It's my baseline personality. On the other hand, if I'm somebody who typically is quite resigned and shy and quiet, if I'm showing loud and boisterous behavior, that may be cause for some further investigation. So as family care providers, we are often the most aware of our loved one's baseline behavior and demeanor. And so that puts us in a wonderful position to be able to inform other care partners involved in care of any changes that we're identifying and help inform them in terms of approach and strategizing to address any behaviors that exist. So it's never the responsibility of the person living with dementia to resolve their own responsive behavior or personal expression. It is our responsibility to understand what's being communicated by the person, how to address the unmet need in a person-centered way, and share those successful approaches and interventions with all involved in care. So we really do have to shift how we think about how to resolve a responsive behavior. And that does sit with us as care partners. So I'm going to go through a few examples of responsive behaviors, and we'll talk a little bit later about some of the approaches and interventions that we might look at for responsive behaviors. What you won't hear from me today are blanket interventions. Certainly I may touch on some different strategies that might be effective, but when we talk about person-centered care, we are talking about ensuring that the strategies and approaches we use are very much individualized, because one person's reasoning or motive behind their behavior according to what's happening in their brain or their life experience could be very different to another's and likely will be. Therefore, we can't just say this one approach works for everybody. We have to make sure that we understand somebody's personal experience, their life history, as well as some of the things that may cause them in agitation or behavior, in addition to knowing their disease process. So these are all pieces that are important in determining a strategy. So I'm going to talk about some common responsive behaviors. This certainly doesn't cover the gamut. There are lots of different examples out there, but these are some of the more common ones we might see. So first of all, collecting, rummaging, we sometimes hear the term hoarding. We try and shy away from that. Again, there's not intent happening here. So this can create a bit of a hazardous environment. So if we look at responsive behaviors in terms of risk, so not only are we looking at a change in someone's baseline, but we're also balancing that with risk. So is this change creating a risk? And if so, how great is that risk and what do we need to do to address it before it becomes greater? So for collecting and rummaging, it may seem quite benign. However, we have to think about that it could contribute to a hazardous environment, perhaps a fire risk. If the individual's living in an environment with other individuals, it may mean going into somebody else's room and perhaps taking their things and hiding those, or those types of interactions become greater when we encounter those who experience that collecting or rummaging. So those are some of the risks associated with that. Declining care or treatment. So this is also something that we can see as disease progresses. And we really have to take great sensitivity when we look at trying to understand why somebody may be refusing care. Certainly there is great risk, or there can be great risk involved in declining care or treatment, such as malnutrition, skin breakdown, dehydration, infection, etc. But we also have to remember that if it's not a loved one providing the bathing, or even if it is a loved one who is not used to providing the bathing, or if it's an external care partner providing the bathing, a person may be quite uncomfortable with having somebody new in what we might call their whisper zone, or the zone that normally nobody else is privy to. That would certainly make me uncomfortable and would take me a while to get used to. And I would certainly hope that steps were taken to ensure that I was as comfortable as I could be in that situation. So we really do have to be quite sensitive to those who may be declining care and understanding what will help them feel more comfortable. Trust is very important in that situation. Exit seeking. So of course that can create harm and risk in terms of wandering into poor weather conditions, going into an unknown home, wandering onto a busy road or waterway, becoming lost. So those are some of the risks involved with exit seeking. Certainly there are lots of resources available, again, for all of the behaviors that we're talking about today, but in particular for exit seeking, really great idea to reach out to your local Alzheimer's Society, because they do often have things like wander guards available, alarm systems, or they can point you in the right direction anyway, the Medical Alert Safely Home program. So there's lots of things like that that they may be able to refer you to. Sexual expression is something that we do like to talk about as well. Examples of that may be exposing one's private areas in a public area, verbal sexual comments, things like that, sexual expression outside of a person's norm, or that may be causing risk to themselves or somebody else. What we do really like to really point out when we talk about sexual expression is we need to remember that human beings have sexual needs, and that in and of itself is not a responsive behavior. So it's important to respect those human needs. However, we do want to make sure that we're supporting sexual expression in a healthy way that doesn't pose risk. So it becomes concerning when that risk exists. And of course, this can become more concerning when somebody is living in an environment with lots of other individuals and the risk becomes a bit greater. So again, we really need to understand what the need is. Sometimes that can just be a needing affection, but not associating other ways of finding that affection. It could be, missing a loved one. It could be no longer having sexual activity at a level the person's used to. So just really understanding where it's coming from in order to address it properly. One way of addressing sexual expression for one person is not necessarily going to work for another. So ingestion of foreign objects or substances, obviously there's risk here in terms of choking hazards, eating inedible items, etc. But it's really important to take a look at why this might be happening. Are they mistaking the object for a food item? Is there a nutritional unmet need that hasn't been identified? So it's really important to understand the cause of something like that. So when it comes to physically responsive behavior, physically expressive behavior, this is one of the more high risk behaviors. This is the kind of behavior we often hear the most about. And really because there is a greater risk for injury or bodily harm to the individual or to others in the vicinity when this occurs, especially within a frail and vulnerable population. So physically responsive behavior may include things like hitting, kicking, pinching, spitting, scratching, etc. Well, we're going to go through a little bit later on the behavioral escalation scale, and we'll talk a little bit about where physically responsive behavior falls on that the escalation scale to help frame it a little bit better. So low mood is a behavior we don't often hear a lot about because we don't associate it with responsive behavior. It's not one of the sort of loud and out there behaviors that we hear about in the media that is talked about quite often. However, even though we always need to think about the risk of others, we also need to really think about the risk for the individual. And low mood absolutely can be a risk for the individual. So this may mean somebody who's normally social and a joiner is now sitting alone in their room most of the time and not engaging with others. So it's important to remember that this also needs to be addressed. So really looking at other factors that might be contributing to the mood. Is there a history of depression? Really looking at how to ensure that the individual is receiving support for their well-being. Self-protective behavior is a bit of a blanket term that we may use for any behavior that is self-protective in nature. So things like repetitive vocalizations, pacing, restlessness, verbal or physical behaviors, where the individual is experiencing a perceived risk. So this may include protecting their environment, so protecting their room, protecting their home, feeling there's a risk there or a threat, protecting their self. So again, during self-care or during personal care or bathing, you may see self-protective behavior there because their perception may be that you are violating me in some way and I need to protect myself. Also of items. So somebody who may be collecting or rummaging or hiding things may be working to protect items that they believe are needing to be protected. So it's important to understand why the need for self-protection is there and to build trust to support the individual experiencing these types of behaviors. So we can also see things like suspicious or paranoid behavior, so fear of abandonment, hiding items, thinking maybe they're being poisoned, so afraid to eat food, feeling someone's after them. So again, knowing a person's history, what have they lived through in their personal life? What is their life experience that they could be reliving now or that they could be experiencing in a different way that's contributing to the behavior? And also really looking at, what are there, if any, are pre-existing mental health concerns that could be contributing to this type of behavior as well. And lastly, we'll talk about verbally responsive behavior. So this is things like yelling, swearing, repetitive statements, things like that. And certainly these behaviors can impact not only the individual, but also those within the vicinity. So especially in an environment like a long-term care home, verbally responsive behavior certainly can feel very disruptive to the others in the home as well. So it's important to learn what's causing the vocalizations. Verbally responsive behavior is probably one of the most normalized behaviors that we encounter because if it's not addressed, it just continues and it almost becomes background noise in a place like a long-term care home, for example. And it can become normalized by those in the environment. That's just Mrs. Jones. She just talks a lot, or she just yells a lot. And we want to step away from that and really do the work to understand what's going on behind those verbally responsive behaviors. Is there pain happening or constipation? Is there what is the unmet need that has not been addressed to prevent them from calling out? So I'll move on to some common approaches to responsive behavior. So again, I try to shy away from giving very specific approach or strategy examples because they really absolutely need to be person-centered. So the PIECES approach is a training that registered staff can receive in healthcare workplaces that is directed towards those supporting people with dementia and responsive behaviors. And it does use the person-centered approach. So when we look at the PIECES model, I also like to share it with care partners. I hate saying informal because it can feel very formal, unpaid care partners as well. So when we break down the PIECES model, the P stands for physical. So that's the first place we want to look when we start to see a behavior. So have you talked to your doctor about the behavior? Has it come up quite suddenly? Has a delirium been ruled out? Is there pain or constipation? Are there other physical illnesses going on? Are there medication interactions happening? So these are sort of the first questions that should come into your mind, especially if the behavior happens quite quickly. And they're a good thing to talk to your healthcare team about. Intellectual, so what cognitive changes are occurring that may be contributing to the behavior? So has there been a change in the ability to communicate? Is that creating a behavior? Emotional, so are the emotional unmet, what are the emotional unmet needs? Certainly emotional support changes over time, and the ability to connect emotionally changes as well. And so are there unmet needs there? Is the person feeling validated, heard, understood, and emotionally supported? The capabilities. So what capabilities have changed that could be causing frustration or may require adjustment to care or new supports? Are they an artist who can't hold a paintbrush in the same way that they used to be able to and need a different utility to do that? So things like that, we want to really look at how do we support those capabilities. The environment. So has anything changed in the environment? How is it being perceived? Always think lighting, color, ability to navigate, who and what are in the environment or not in the environment that can be changed to create more comfort or to reduce triggering items. And then lastly, we have social. So is social engagement occurring in a way that is preferred by the person? So we can't assume everybody is social. Everybody has their own preferences, whether they have dementia or not, in how they want to engage socially, but it's important to understand how a person likes to engage and meet those needs. So again, always think about what you need to change, what we need to change to help accommodate that dementia, disease progression, as well as responsive behaviors, not how the person with dementia needs to change. So we're thinking about sensory input, communication, social and creative strategies, meaningful activities. So there's not one single activity that every person with dementia is going to enjoy. We can't always assume what somebody may have liked earlier, they'll like now. So it's important to try different things as well. Offer choice in a simple way. So changing our communication style, changing our approach is a great way to start approaching. Validate, absolutely validate feelings, even if you don't quite understand them, even if you don't are having trouble communicating, we can all validate by nodding, by touching a hand. I know that if you're in a care environment, those types of touching and close contact aren't possible during COVID, but we can find other ways to validate as well. And doing nothing is having a plan. So if behavior is occurring and you don't know what to do, take a step back and reapproach later. So I'm quickly going to go through the responsive behavior, behavioral escalation model here from AGE. We always want to use unconditional positive regard for the individual in any stage of escalation. I apologize for the very dramatic color scheme here, but it was sort of the easiest way to lay things out. So we talked about baseline earlier, and at baseline, a person really requires no intervention. This is their normal state of being. They may be supported using their established plan of care, the things they like. This is where we want everyone to stay. This is where I like to stay, is at my baseline. And so it's important that we know those person-centered tools and approaches to keep somebody here. The next behavior that escalation we may see is anxious behavior. So when somebody starts to leave their baseline, typically we'll see some anxious behavior. You may recognize at this point something needs to change. So this could be, somebody pacing, it could be a different change in their facial expression, things like that. So give them some space, validate, allow them to vent, identify and remove any external stimuli that could be contributing to the behavior, and try and create trust and calm. Remember to always use unconditional positive regard for the individual in any stage of escalation, that this is not something they're intending. They are absolutely working with the brain that they have, and it's our responsibility to figure out what's going on and help to reduce that. So the next stage we might see is verbally responsive behavior. So this is an indication that things might be escalating even a little bit further. So again, support using the person's personhood, remain calm, speak to the person clearly, slowly, and present yourself from the side and at their eye level. So we don't ever want to stand over somebody or come across as a threat to them when they're already in a heightened state. Be aware of your nonverbal cues. So, stay calm and reassuring. and try to provide all of those supports that they may need to help de-escalate from here. Once we get into physically responsive behavior, that's typically that last stage of escalation we may see. Please note that this isn't the way it goes every single time. This is the most common escalation scale that we do see, though. Sometimes these stages can be very quick together, and you may not even identify the anxious or verbally before it gets to physically responsive. You just may not have a chance. But usually when we think back and we debrief, we can identify, oh yes, okay, there was a little bit of this happening before the physically responsive behavior. Oh, there was that going on in the environment. So once somebody does become physically responsive, we do recommend, this is, and think about your own self when you're very, very heightened. The last thing we want usually is somebody in our face, touching, sort of, this can promote an increase in physically protective behavior. We can also be perceived as a threat at that point for somebody who's already physically responsive. So it's important to ensure that bystanders are removed, that they get their space, that they're validated from a distance and reassured from a distance, but allow them to de-escalate in a safe environment where risks are reduced. So that is, in a nutshell, what the behavioral escalation stages look like. Again, they don't all perfectly look like this every time, but this is the most common event unfolding that we see. So I just want to talk briefly about the COVID-19 pandemic and the impact on responsive behaviors. Of course, it's changed how those living with dementia and their care partners are experiencing their environment. It's also changed what approaches and supports are available to them and their care partners. So in terms of isolation, whether in long-term care or retirement environment, increased isolation has contributed to responsive behaviors. Transitions to a new environment without the typical supports available, of course, an inability for family care partners to support as much as they'd like, or in a manner that's not as familiar, has contributed as well. Not having access to previous supports and services that were available, or access in a different way, or less access. Requiring additional support from unpaid or family care partners. This can result in a lot of compassion fatigue, additional stress and time for those care partners as well, and less in-person support from unpaid care partner, from those care partners that we access. So navigating virtual care and helping our loved ones understand what that means. So we're fortunate to still have an awful lot of care to draw on, but certainly the pandemic has changed what that looks like. So I'll briefly discuss where we can go for support. So Behavioral Supports Ontario is a provincial program that exists to enhance services for older adults with complex responsive behaviors associated with dementia, mental health, addictions, and other neurological disorders. And this goes right across the entire healthcare sector. So long-term care, community, hospital, BSO supports are available across the healthcare continuum. BSO teams exist in organizations all across the healthcare system. They work as a collaborative unit to address and support individuals with responsive behaviors, no matter where they are, and as they transition through the healthcare system. So I've put a link there. Each Behavioral Support Ontario program in each region of the province is a little bit different in terms of what those supports look like. So you're best to connect directly with the BSO in your area. I also want to touch on the Alzheimer's Society. This is a key and crucial support for anyone supporting somebody with a dementia and a responsive behavior. So your local Alzheimer's Society, you can reach out to them for support and for in a lot of different ways. Each, again, just like BSO, each Alzheimer's Society has a different complement of supports, but that can include a variety of services ranging from navigation to counseling, cognitive assessment, education, respite and day program supports. Alzheimer's Society are often, and I think in just about every region, a primary partner in the BSO program as well. So they do work hand in hand. So I just want to, lastly, a couple more resources that are available for those that want to check out some COVID-19 resources. Our Brain Exchange portal is a wonderful way to access different COVID-19 resources, and they do actually have a family care partner resource for COVID-19. So the link is there, and I think that Susan's going to make sure that all of the links are provided to you that I'm offering today. So those are two really, really great places to go for care partner resources as well as COVID-19 resources. The Dementia Isolation Toolkit is a toolkit that was developed to be used in care settings like long-term care and retirement homes to help those in isolation who may experience responsive behaviors. A wonderful tool. It may not be a tool that you may use at home if you're a family care partner with your loved one, but I think it's a great tool to help walk through some of the things you may want to think about if you're in isolation or if your loved one is transitioning. We also have the Transitional Care Plan during the COVID-19 pandemic that was developed, another wonderful tool used by our healthcare partners across the continuum to help support people with the dementia and responsive behavior as they transition between sectors. So it's something you can access and look at if you like to, just so you can see the kind of tools that we're using to help support your loved ones.
On behalf of the Ontario Caregiver Organization, I want to thank Alzheimer's Society of Ontario and Krista Schneider for being here with us today.